The bottom line is mental health doesn't choose if you are a nurse or well-educated or a homeless person. It hits everyone at their lowest moment. So treat everyone with kindness and, treat them well with respect, and it all comes back to you.
Here we go. Welcome, everybody, back to the Badass Motherfucker podcast. We have our special guest today, Ramon Yu, charge psych nurse out of Marin, California. Ramon, how are you?
I'm good. How are you?
I'm great. You were telling me right before we started that you've been a nurse for a long time.
20 years.
20 years. And how old are you now?
I'm 60.
Thank you for taking the time out of your day to chit chat with me. Your coworkers, Carmelita and Kim, have said amazing things about you, that you are a majestic unicorn that needs to be experienced in real time.
Oh my goodness.
How does that make you feel being described like that?
I am flattered.
Yeah. You work in the psych unit at a hospital in Marin, correct?
Yes, at Marine General Hospital.
How long have you been there as a psych nurse?
20 years to be exact.
At the same place?
Yeah, I never left.
What's a typical day like there for you?
Well, in psychiatry, there's no typical day. Sometimes you come in with bright blue skies, and then suddenly a category 4 hurricane comes in. The unit seems to be quiet at first, but it becomes chaotic. Bottom line is always check with the patients how they're feeling and what are their needs. Otherwise, if you miss that, then that's where trouble comes in. For me, I not only check with the patients, but I also check with my coworkers because, sometimes they're going through a rough day, and I always check on them. Are you okay? Especially if I notice that they're not in their A game, like, oh, something's wrong with this staff. So I pull them aside and ask them if there's anything I can do to help. And they tell me, and I ask them to, you can step out for a while, check yourself and come in when you're ready. And that helps a lot. So sometimes if a patient doesn't go well with a nurse or a staff, you have to step in and try to mediate before accidents occur or incidents happen. So that's my typical day. I always check on everyone.
That was actually one of the main things that your coworker Carmelita, who is a psych counselor, I believe that's her
Yes,
title.
yes.
That was the one thing she said about you. You were really good at always making the people around you, your coworkers, feel very safe, which she really appreciated. But I wanted to ask you, like, how do you make that judgment, that call? Is it just through experience? What have you learned?
Sometimes it's through instincts. Like you feel like, oh, this nurse is not compatible with this patient, so I switch. Like I'm giving this patient to so and so, and you're taking care of this patient. Because sometimes their personalities clash. Like they're both like alpha male, and that doesn't work well in psych because they just power struggle. Because you can't let it happen, like watching them not doing well with their relationship. I jump right away, like, let me help you, but not in a way that's not embarrassing to the staff. Like sometimes I call the staff, like, oh, you need to do something, and I step in. Or sometimes if the patient is looking for the staff to get his medications, I don't wait for the staff to come back. I just give the medication right away. Because the bottom line is I work in an acute psych unit. So most of these patients are either not medicated, off their medications for a long time, or refuse to take medications. So I keep on telling everyone, medicate, 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 because, that's what they're here for. And when they're better, that's when they go to their primary physicians once they get discharged from the unit.
Has any unfortunate incidents happened
Oh, a
that you
lot.
remember?
When I was still orienting, maybe my second night orienting as a psych nurse, I had this incident wherein a patient AWOLed at 5 in the morning. So I was very fresh, like off the boat, fresh off the boat. Um, I don't know exactly everything yet, like the rules and the policies and procedures. So when a patient AWOL, I was chasing the patient, and the patient walked all the way to the highway. And the patient is Spanish speaking only. So I was like trying to remember whatever Spanish words I can recall in college. Let's just call him by Jose. So I was just calling him Jose, Jose, cállate, cállate, ven aquí, Jose. But of course, he never listened to me. He keeps on walking. So I was chasing him until the police came. So when I got back to the unit, the charge nurse that time, because I was still orienting, was telling me like, Ramon, next time, do not get out of the hospital, because once you get out of the hospital premises, they are not liable of what will happen to you, which is true. So you don't get paid for that if somebody stabs you, or you get run by a car or something. So those are the things that you learn through experience, and that's the one thing that I can never forget. So now that if a patient AWOLs, we just call security and the police, and gives them description of what they're wearing, and they'll be the ones responsible to take the patient back to the unit.
Have you ever permanently lost a patient?
No, fortunately not. There are times wherein patient AWOLs during the day, and the family takes the patient back to the unit because the patient has nowhere to go but home. So the family would take the patient back, but not on night shift because I work night shifts. I work 12 hours night shift.
Have you always worked night shift?
Yeah, I've always worked night shift for the past 20 years.
What is it about night shift that you like so much?
Well, first of all, there is no administration on night shift, so there's less trouble. Like it's less busy. The doctors are not there, so you just call them if you need them. And the patients are there. They're mostly medicated already throughout the day, so they're less agitated. They're less. They only sleep during the night. So
Because I don't know how it is with psych patients, but I know in the ER sometimes we'll get patients the ones who don't sleep through the night, especially some of our geriatric patients who start sundowning and are up all night. Does that ever happen?
yeah, we get patients with dementia, but we don't usually take demented patients. But they're the ones with a co-diagnosis, like they were bipolar before when they were younger, and now they're having dementia because they're in their 60s or 70s. So we have no excuse but to take them. ER and psych, they don't mix well because the ER always likes to push patients away because they're very busy, and I understand that they're very busy. But there are times wherein the patient is not ready yet to be transferred, like patient has a BAL of 300. We don't take those. They have to go down to at least 100 BAL before we can take those patients because there's nothing we can do. They're very intoxicated. And the psych social worker has to assess them in the ED. So when they're intoxicated, they may not be psych because sometimes when you're intoxicated, you say something silly like I'm suicidal, I want to hurt myself. But when you're sober, you don't mean it. So the social worker in the ED has to wait for them to sober up before she can assess them and say, oh, he's really a psych patient, or oh, he can go home.
Has someone actually tried to send you a drunk,
Oh, yeah.
supposedly psych patient?
Yeah. I just put him straight to the seclusion room, because I can't put him in a room with two other patients because we have private rooms, we have dorm rooms, meaning they share it with two other patients. It's a bedroom. So you can't put him there when they're drunk because they're just gonna wake up those two other patients. So you have to isolate them.
I thought the process of transferring a patient to your psych unit would take long enough where they would sober up from being drunk.
Yes, yes, yes.
I never realized that they would actually show up to your unit still drunk, but that happens.
It happens sometimes because we have two port of entry, the emergency room, and the crisis unit. So the ones who go to the crisis unit, sometimes they don't take the BAL, or at some point, I guess the patient is not assessed very well and they just want to get rid of the patient. So the patient comes to us with alcoholic breath, like, oh, no, this patient is, drunk or something.
When you get put on a psych hold and you get sent to the psych unit, if you're just drunk and you wake up, you're sober, and you're not feeling like that anymore, does any of that go on your permanent record that you were in the psych unit or put on a hold?
When you're in a 5150, yeah, it goes to your record.
Right?
Of course, they get discharged the next day, but I believe it goes to your record.
Yeah. So I mean, that would be really unfortunate that if you just had one of those crazy drunken nights that a doctor put you on a 5150 hold, and now you have you know
That's why the social workers in the ED, they're very good at it. They don't put anybody on hold when they're drunk. So they have to wait for them to be sober, assess them if they really need to go to the psych unit or, send them home. They have to wait. ED cannot do anything about it. Even if they want to get rid of the patient, they have to wait because they cannot be assessed when they're drunk.
it feels like in the ED, at least when I was working, we could never get rid of these psych patients. It would take
Yeah,
days.
they're always there every night.
Yeah.
Even if they're just drunk and they keep on saying all the suicidal, things, you cannot assess them or put them on hold until they get sober. And, they say like, oh, I'm just saying that because of this and that, but I'm not really suicidal.
Yeah. When I left the ER, we actually started hiring psych technicians that were
Uh-huh.
specifically just for psych techs. And now you see nowadays, a lot of nurses are getting their psych NPs. And
Hmm.
I heard recently that there are places like Hawaii that have
Uh-huh.
psych nurses, and that's all they do in the ER, just to take care of psych patients. I mean, this problem was always a big problem, and now they're finally trying to do things to solve it. But like, well, you've been in this for so long. What have you seen on your end that's changed in the last 20 years with all these new psych jobs popping up?
Well, before I started working in the hospital, my mentor, the one who was training me, she was the charge nurse on nights for many, many. She retired already. She said during her time, they were asked to go down to the ED to assess psych patients. Like, how does that work? You're the charge nurse here in the unit, and then you go down to the ED to assess psych patients, and that would take. Sometimes it takes you all night. And she said, like, well, that's a system before, and they don't have a lot of psych nurses, and you have to do both ED and the unit. Like, oh, that's very toxic. But when I started, they have designated psych social workers who are assigned in the ED, and they're the ones who deal with the psych patients in the ED.
Designated psych social worker, but there's still social worker for all the other patients too, or is there a psych social worker and
No,
a regular
there,
social
there's
worker?
there's only one that's assigned in the ED. She's designated to stay in the ED for psych patients. And she's the one who's gonna call the doctor. She's the one who's gonna put the patient on a 5150. And if the patient needs to come to our unit, she's the one that would arrange everything. And then we take the patient. But we don't deal directly with the patient while they're in the ED. It's a social worker.
Yeah, I can imagine there'd be a lot of pushback between that charge nurse and the ED doctors and the nurses of the ED. He is
Oh
a psych
yeah.
patient. He's not a psych patient.
They try to fight with us, like, why can't you take this patient? Patient is like this and that. Like, well, that's not how it works. Sometimes I go ahead and I call the nurse supervisor right away to make her aware that this is going on. So she will be able to mediate with the ED charge nurse and me. Because if not, then it's hard to communicate with them because they have their own decisions and we have our own policies. So, you know,
Yeah, it definitely feels like when I left, there was this disconnect between the psych facilities and the ER.
yeah, it's very common among, I think in every hospital, that's the problem.
Yeah, and so now what we're seeing is that, Now there are designated psych nurses in the ER, designated psych techs, and now I think we're moving on to psych NPs to kind of bridge this gap of misinformation about like, okay, well, what are really the rules and what are the policies, so we can all try to get along in this crazy world.
Yeah, that's true.
One thing that your coworker said about you is that you build such great bonds with your patients, so much so that when they would come back to the psych unit, sometimes you get recurring visitors.
Uh-huh.
They would ask for you by name.
Yeah, and I'm surprised about that. But the only thing I can remember is that these patients, what they remember about you is how you treat them while they were there on the unit. And that's the only thing that reminds them of you. They will look for somebody who they feel like, oh, I feel comfortable, working with you. And because I think they can sense the sincerity when you talk to them and deal with them or communicate with them. And that's a big plus for their compliance with like taking medications. Sometimes the patient would not take medications from anybody else if they don't like the staff. So it's a big plus to have a good rapport with the patients.
What do you say to those people who say, like when you're treating patients in this population that just feeding them meds is just bad and not the way to go?
Yeah, a lot of them get embarrassed, like, oh, I messed up. I have to take these medications. And well, I tell them, you know what? We all go through this. Like any one of us can be a patient here. Not only you, but us also, the staff, the doctors, the nurses. We can be patients too. You're not here because you messed up your life. You're here to get better, and we're here to help you. So if they are assured that they're not a bad person, like, oh, I messed up with my life, I need to be here, like, no. Because we have patients that are nurses, doctors, lawyers, or celebrities. At one instant, I met someone who is also a nurse on the hospital. The reason why I met him because we always arrive like at the same time at the parking lot, the parking garage. Like, hey, how are you doing? Blah blah blah. And he seems to be very nice until one day I saw him as a patient on the unit. And I didn't know that he already was not doing well in the med surg unit and until eventually he got admitted. So I just deal with him like the way I was dealing with him in the parking lot. Like I did not treat him as a patient. I treat him like coworker. And he was very appreciative of that. And when he got discharged, he was very grateful. I don't think he's still working in the hospital. I think he left. The bottom line is mental health doesn't choose if you are a nurse or, well educated or a homeless person. It hits everyone at their lowest moment. So treat everyone with kindness and, treat them well with respect and it all comes back to you and it makes things easier for everyone.
Such good advice. But again, coming from the ED, it's such a different environment. It gets so hard sometimes to kind of slow down and remember those things and remember that like this is a person who's just looking for help. Because in the ED, like for me personally, there's just always a million things going on, and it's easy to see a psych patient walk in and they're saying that they're not feeling well, just to just be like, all right, just sit down and wait. Like, I got other things going on.
Yeah, it is very busy. It's crazy out there. They go in like what do you call this? Code black or something because patients are lying in the hallways and it's just very busy. Most of the time they don't have enough staff to spend time talking to the psych patients. Most of them just need to be heard. And once they have vent and, they have said what they want to say or something, they feel better and they're more cooperative with treatment.
So what I've heard in your psych unit is that these patients have rooms, but you don't lock them in the room. They are
No,
free.
no.
They are roaming around the unit.
Yeah.
So that was interesting to me. I didn't know that. I didn't know the patients were just allowed to walk around, and so like are they at the nursing station talking to you? You're not in the room talking to them.
Our unit is built in such a way where it's like in the middle is like the common room, the day room where they can eat, talk. They do meetings there, and the rooms are like surrounding the unit. So we have like one, two, three, four, five, six, seven private rooms. No, eight private rooms and three dorm rooms. We only have a total of 17 beds on the unit. So the group rooms can either be a male dorm room or a female dorm room. It's co-ed. It's not like a separate unit for males or separate unit for females. And you know how it goes. Sometimes when psych patients, when they're unstable, some of them gets hypersexual or, you know, so you really have to watch them. There was one experience I've had. This was years ago wherein the mental health counselor caught a patient having sex on the unit. So they called me. So I rushed to the room and asked the man to get out. Guess what he told me, which is very iconic and very, you can never forget this. He was on top of the female and he was like, "Oh, I am just doing CPR." And I said, "You don't do CPR on the V. You don't know CPR on the V. Get off her." It's either you get off her right now or you go to jail. So I pulled him out. I pulled him aside and I talked to him like, "I am not doing this to embarrass you. I am doing this for your own safety. You know, we've had patients here who got jailed for doing that. It's because this is not a typical unit. You're in a psych unit. A lot of patients here, they're not in their stable mental health. They cannot decide what's right or what's wrong. So when they get better, they remember like, oh, this happened, so I'm gonna sue you for raping me or something, and you're gonna get in trouble. You're gonna go to jail," which is true. So he was very thankful for that.
That's such a random off the cuff excuse. He was just like,
I know.
these were both patients in the unit.
Yes, those are both patients.
So what's happened is that like if two patients in the unit end up having sex, and one gets out and is says, okay, I'm in the right state of mind now. I didn't want that to happen. You could sue the hospital or this.
More often than not, the person, the one who did it, but
Gotcha.
it seldom happens, but it did. And that's why I always tell everyone to be very cautious and be like guarding with your life. If I sense like, oh, she's kind of like hypersexual or something, guard her with your life and never allow. Because they flirt with everyone, and then some patients would try to make excuses like, but we're both adults, like we can decide on our own. Like, yes, you are, and you can do that, but remember, you're not in the medical surgical unit. You are in a psych unit.
I mean, even if you were in a medical surgical unit,
Yeah, I don't know what's going on there, but or ED, I don't know, but being in a psych unit is different because you don't have insight, your judgment is faulty. Sometimes you don't even know what you're doing. So yeah, it's different. You can be sued for that. You will be held liable for your actions. You're in a psych unit. It's a different unit than, all the other units in the hospital. I know it
wow.
happens on all the other units, but it's different, But in a psych unit, it's a no-no.
That's a lot of things that, like, again, I didn't know about the psych unit, and I'm sure the general public listening in probably doesn't know either. Is there anything else, any other significant little tidbits that you think the general public doesn't know about?
There's a lot of things that the general public doesn't know or is aware of working in a psych unit. They don't know, like when you work there, you can be abused verbally, you can get assaulted, anything can happen inside unless you tell them or you make them aware of that's what's going on. All they know is that they don't want to deal with psych patients, and because it's difficult to communicate with psych patients. It takes an overwhelming amount of patience to talk to them. because sometimes, especially when they're very psychotic and delusional, there is no way you can talk to them out of it. Once they get better, they change and they are a totally different person. And they're very grateful about it once they are aware that, oh, thank you for taking good care of me. And they apologize for their bad behavior. Like I apologize for calling you names or, give you a hard time, but now that I'm better, I'm so sorry about it. It gives you a boost, like, oh, thank you, but you need to take your medications, even if you're discharged from it, because a lot of them stop taking their medications once they get out of the hospital, and then they compensate again, and we see them in a couple of months, and more often than not, they take drugs on top of it, they drink. So, it makes it worse. And lately, all these patients, like we have this fentanyl crisis here in the Bay Area. Aside from fentanyl, with this meth and all these drugs combined, it brings out a different population of psych patients. They're kind of like more aggressive, more hostile, more combative, and hard to treat. You have to have a good team to avoid accidents on the unit. That's why I keep on telling them, if you're not feeling well, don't come to work, because it's either you get hurt or you might let your coworkers get hurt if you're not on top of your game. The population is changing and it's scary.
You're seeing it's changing because
Of these
um,
drugs, that's
of the drugs.
the new ones. It has changed them a lot. Like,
Have you seen an increase in hospital workers getting injured at work because of it?
if you go to other psych hospitals, there's a population, like let's say John George or Atascadero, where all these forensic psych patients are. Oh, they get injured every day. I know somebody who works there. They also work at our hospital. Like, oh, this is heaven, they said, because the at my other job we do takedowns like every 5 minutes. There's a takedown and they get injured, they get hit, they get assaulted. But in our unit, fortunately, for the past 20 years, we have a takedown like what, once a month. So our population is less hostile or less acute than the rest of the psych units in the Bay Area.
I used to work in the Bay Area. I was at Stanford for the longest time.
I heard.
But definitely coming in and out of San Francisco. I live in LA now, so it's almost just as bad. But San Francisco is probably one of the worst places in the country I've ever seen when it comes to,
Homeless people.
homeless and
And it's
drugs.
getting worse in LA too, right?
It's getting pretty bad.
The worst is here. Like, I don't go to the city anymore. It's not the typical San Francisco that you remember years ago. You know, a lot of stores have closed. You see all the tents everywhere, people shooting drugs in the streets, and it's depressing.
Yeah, that was the most shocking thing when right before I left. I used to take the BART because I used to do theater in San Francisco, and I would get off at the Civic Center station. That was
Oh,
like
that's the worst station.
that's that was like the worst stop, you know?
Yeah,
You're walking up the stairs from the tunnel out of the BART, and there are people on the stairs just openly shooting drugs into their veins.
exactly.
I
Yeah.
was like, this is insane.
Yeah, and we go up out of that station at the civic center. There's like a tent city. Like, everybody is putting tents there, all the homeless people in the plaza, like, what's going on? And now it's kind of like a tourist attraction. Like, if I have visitors from Philippines or anywhere, when I drive them around the city, like, oh, see these homeless people, they're shooting drugs to your left, and they're defecating on your right, and like,
Oh.
yeah, it's crazy.
You go to the pier, you look at the walruses, you go to Civic Center, you see some homeless people, you take some pictures, you go back to the Philippines. It's perfect.
Like, it's better there, you know.
Again, you worked for a very long time. Like, how did it get so bad?
I think the system is broken. Like, our politics and our it's broken. The system is broken. It's hard to pinpoint who did what, but it all comes down to people getting more and more entitled. Like it's my right to do this, it's my right to do that, and nobody is governing, like telling them the right thing to do. Everybody has wants and needs to do what they want without being there's no consequences. You know what I mean? So yeah, it's the system is broken, I would say.
It feels like there's also this entitlement, yes, but people there's this kind of this know-it-all mentality too,
Yes,
where like
yes.
like
Uh-huh.
I don't need to listen to the people that have been there before. I know what I'm doing. I have enough information. I have TikTok University. I know how the world works,
Exactly. Yeah, you
you
just
know?
Google it and they seem like they have already a PhD or, master's degree in something.
Yeah, you're right. So I don't really have an explanation for it either. Again, I'm talking to a lot of nurses around the country, and they all say the same thing you're saying. It's patients for some reason are getting more aggressive. They're getting more
Yeah,
entitled,
true.
and they're getting more entitled.
Yeah. And also the facilities, where we need more psych beds, we need more mental health centers because a lot of people are stressed nowadays with what's going on with the world and because it's overwhelming.
Yeah, and what ends up happening is once you have a bad thought in the day, when there's nowhere else to go to give you proper treatment, where do you end up? In the ER,
Exactly.
where if I'm being totally honest, we don't know what the fuck we're doing in there.
Exactly, right? Because
So we're gonna make the problem worse.
yeah, because the police once they take this unruly patients, they always take these patients to the ER, and sometimes they're already on a hold. The police has put them on a hold. They don't need to be on a hold. They're just belligerent for like high on drugs or something. So the social worker in the ED will have to call the doctor to lift the hold because they can't let the patient go if the patient's on a hold. Or if the patient really needs to be admitted, there's no psych beds. We're always full. So they have to refer them to other hospitals, which are always full also. So sometimes they stay there for days.
Yeah, so you stay up in the ER for days. We don't know what to do with you. We're not treating you
Yeah, true.
correctly, and and the patient ends up thinking like, oh, like like nobody wants me. System screwed me. No one's helping me.
Hmm.
You know,
They,
why
they
aren't you
get
getting
more
what? They
suicidal.
get more suicidal.
Yeah, because
They're
they
like
feel
what?
unheard, they feel unwanted, and yeah.
They feel absolutely unwanted when I keep coming into the room and telling them, hey, your bed's not ready yet. We don't have space for you. You're gonna have to be here for a while in this
Yeah,
ER.
true.
You know,
And they get more agitated.
they get more agitated.
All you can do is probably like, do you want a sandwich or a warm blanket or make you feel comfortable for the
Yeah.
night? Yeah, sometimes it works, but it's the waiting that makes them, you know.
And we just and we definitely just need more help. I have this joke I'm trying to work out that it's a bit, it's not really a joke, but there's it's just at 2 a.m. in the morning, what's open for people who are having bad thoughts in their head, right? They're not going to go to a 7-Eleven. They're going to call the police, and the police aren't going to know what the fuck to do. The police are going to send
Yeah.
you to the ER, right?
Uh-huh.
And what can the ER do? Oh, you can stay here, change. We're going to strip you, take your stuff away,
Yeah.
put a big security guard right in your room to watch you the entire night, make you feel like a freaking zoo animal, and you just have to wait.
Sometimes we call the unit. Sometimes I get calls from people who are suicidal. I don't tell them to go to the ER. I tell them to go to the crisis unit because we have our own crisis unit. Like, no, you have to go to the crisis unit if you feel like you're in crisis. Don't go to the ED because you're gonna be there for a long time and nobody's gonna talk to you because they're all busy. They only have a social worker there to assess you once, she's available, but sometimes there's like 4 or 5 of you there. So you have to go to the crisis unit and I give them directions to go to the psych unit. And I don't know how to go to the psych unit. Well, call the police, ask the police to bring you to the psych unit. the crisis unit. I mean, yeah, that's how I tell them when they call our unit.
Can you explain a little bit more about the crisis unit and where what it is and how to get there for people?
Well, the crisis unit is it's not part of the hospital. It's a county. The county pays for that. So if you think you're undergoing crisis, you're suicidal or homicidal, or you can take care of yourself, or you're out of your medications when, like, if you're a patient taking medications and you're out of it and you don't know what to do, we encourage them to go to the crisis unit, which is just next to our unit, but it's not part of the hospital. It's the county crisis unit. And I think every county has that. They have a crisis unit, a psych crisis unit. A lot of patients go there first before being assessed to, oh, you need to be admitted. Then they go to our unit. If not, then they go somewhere else or go home. It's
Open
called
24 hours.
PAS. In other counties, they call it PAS, Psych Emergency Services,
PES. Oh, yes. Okay. Yes, yes, yes.
or CSU, Crisis Stabilization Unit. That's the crisis unit we call it.
Okay. Yeah. Great advice from Ramon. Yes. Crisis unit. Do not call the police and go straight to the ER. We
Stay there
will make it
forever.
worse. We, you'll stay there forever and we will make it worse. I promise you. You've given such like a lot of really good advice already, Ramon, and I appreciate it so much. Again, talking to Kim and Carmelita, some of their main points about you is that you have a fan that you like to
Oh, a big one.
you have a big fan that you kind of just carry with you in the unit. And there was one time where a patient came up to the nursing station and was yelling at you for food, and you didn't react. You didn't say anything. You let them finish yelling, and then you pulled out your fan. You opened it up. You started fanning yourself, and then you said, "Are you done yelling at me? Once you're done yelling at me, I will go find you something to eat." Very calmly.
I don't do it to everyone, like, because sometimes there are patients who's been there for like more than 10 years and you know them very well. So you can do that to them, because they know you well too. Yeah, but yeah, I admit I have that, and it's just for fun, because sometimes we need to have some fun on the unit when everybody's stressed out, and so sometimes I make jokes or make your work less stressful by being funny. When I started being a charge nurse, when you have your team already, so I used to message them before I drive to work, and I always ask them how is the unit, and if they respond like, oh, it's very bad, or oh, it's chill. So you because I like to psych myself driving to work. Do I come in as Miranda Priestley in The Devil Wears Prada, or should I come in as Mother Teresa? You know what I mean? But always chill, it's calm, like, oh, okay. So, because the moment you come in, you're in a role, like you have to maintain it all throughout. And because the patients can sense it. Like if you're calm, they calm down. But if you are fearful, they can smell fear miles away. Like,
They
oh, I
can.
can eat this person, alive. There are patients who are trying to test you. Like they're very testy and they're very like pushing your buttons. Like, oh, try me.
Like I tell people too, like it's not always like serious, even when it comes to psych patients, it's not always dead serious. Sometimes, you treat them. I compare it to treating them like a coworker or a friend that you've worked with for a long time, because they're frequent, they're there, they know the process, you know the process, you're familiar with each other, there's room for jokes. There's a
Oh,
little bit of
yeah.
room for
A
jokes.
lot of them respond to humor. Yeah, as long as you do it appropriately, like nothing
Yes.
indecent or whatever. Yeah, they respond to it very well
Yeah.
because they know they're taken well cared of. If sometimes if they start screaming at me, I tell them, if you scream at me, I cannot hear you. If you're in your normal voice, I can hear you better. So what's your problem? And they come down like, oh, blah, 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 blah. Okay, so we're going to deal with that. And then, yeah, they respond to it.
Yeah. I think it comes down to, listening to them and responding in a way, responding to how they are acting in real time, as opposed to just having a default response to being
Yeah,
like,
yeah, yeah.
sit down, take your meds.
Oh, yeah. You have to listen to them first before you tell them what to do. You don't like react right away. Like when they're mad, you're mad. When they yell, you yell. Like let them do their thing, and then we'll talk about it.
Have you ever had an incident where maybe you responded incorrectly and you learned that, oh,
Oh yeah, it went the wrong way.
can you tell us about it?
They don't. A lot of these patients don't like to hear no for an answer. Like, can I have this? And you say no. They react differently. Sometimes you just deflect. It's still a no, but you're not really saying no as an answer. Like, can I have this? Like, yes, you can, but not right now. Let's deal with this first, and then we'll see how it goes. It's still a no. You're not giving them what they want, but you're deflected. It's on something that distracts them, and then they forget about it, and then it goes well rather than you telling them no, because
Yeah.
no per se is like you're asking for a fight, and they know that. Divert it some other way that is pleasing to their ears, just not the word no. Yeah.
Good advice, which, brings me to another point I have. I could talk about psych patients all day. Again, I've worked in the ER for 10 years, and there was just such a huge part of my job. Most of the population coming into the ER are homeless, psych, and just learning how to deal with them over the years was just so crazy. But hearing you talk about it is very refreshing. Like,
Oh,
and I think that's one of the things Kim said too, that it's so nice to like know you and know that you are in the exact job that you are supposed to be at, because you do so well in the psych unit with this patient population. She says that there's a lot of people who work in the unit who are very disgruntled, which, is the same for, a lot of psych workers everywhere. But you specifically, I could tell, love your job, you know,
you have to love your job to stay there for a long time.
for 20 years and working night shift
Yeah.
of all shifts. So Ramon, man, I mean, you are a badass motherfucker, and I'm so happy they nominated you. They nominated you for this because like this is who we're looking for. Healthcare workers around the country who are not burnt out, who are still, passionate about their job and who are still willing to teach everybody the best parts about it and, the not so great parts about the job. So I love you, man.
Oh, thank you.
I'd like to end the podcast with a few questions. One of which you gave so many already. What is the most important lesson you have learned over your 20-year career as a psych nurse?
Well, for me, it's not a lesson, but I think it's more of my personality. I always tell everyone, especially the new ones, to always be kind to everyone because you don't know what they're going through. It could be a daily struggle or a long time, event. And your kindness makes a lot of difference. You treat them the way you want to be treated. It pays back, you know, and it never fails. I would say the younger generation, where all they do is the gadgets and everything, they don't have that human touch, the person to person talking. They don't take it as important as what they're doing in social media. And while I'm a baby boomer, I enjoy talking to people about emotions, which you cannot deal with the gadgets. So I always tell them it makes a lot of difference wherein you do a heart to heart talk with your friends or anybody, your coworkers, because it gives you self-awareness and a check-up with their emotions too. Like sometimes people are not willing to tell you what they really are feeling. It may embarrass them, or they don't feel accepted. So it's very important that you yourself would check your friends, yourself, how they're doing, because it makes a lot of difference.
Yeah, no, that's so important. Please check up on your friends, make sure they're okay. The and one last question is I do a series online called Tips from the ER where I give tips.
I watch all those.
You watched them all. Yeah.
Yeah.
And so I like to ask our guest if you have a tip from the psych unit, what is one thing you wish people knew before coming into the psych unit, either let's say as a patient? What's one thing you wish they knew before maybe coming in?
We get a lot of entitled, demanding patients in the psych unit, of course. So once they check in, I tell them you are checking in the acute psych unit. You're not checking Waldorf Astoria or Four Seasons. So you can enjoy the 24-hour room service or filling up your menu, but most importantly, for you to get out of here and get better, you have to take your medications. Because sometimes they forget and sometimes they refuse taking their medications. Like, I can get you what you want, but you have to take your medications first and foremost, because that's what's gonna make you better and get you out of here the soonest possible.
What do you think the biggest obstacle is for like people in taking their medications? Why do so many people just not want to take them?
Well, most of the psych meds, they're kind of sedating and they're kind of like blunts your affect, or um, they don't want that because they want to be a lot of bipolar patients. They want to stay in their manic phase, like, very jolly and very hyper. They don't want to be in their like depressive, very calm state. They don't want that. So they don't want to take their medications because they don't want to go down to that level wherein they're like, oh, I'm depressed. Oh, I don't feel the high anymore that when I was manic. And they stop taking their medications because they want to go back to being, hyper. And I keep on telling them, well, you know, you're at that point wherein you are still adjusting your medications to put you in a stable level and not get you in trouble by being manic. When you're manic, you're hyper shopping, you're hypersexual, you cause trouble outside. And, we don't want you to be like that. We want you to be in a stable state wherein, you can take care of yourself appropriately.
That's good. Good tip. Don't be afraid of the meds. I tell people that too. Not on the level you do, but like I have friends who are also not in
Oh,
the
yeah.
same way, but they're just people are just afraid to take medications, and I'm just like it was made for it was made for a reason. It's there to help. So don't hesitate.
Yeah, for the young ones, some of the medications like antidepressants, they cause like erectile problems. So they don't want to take that. Of course, who wants to? I just tell them, well, talk to your doctor and have your medication changed. I'm pretty sure there's something else that doesn't cause that as a side effect. And yeah, and the doctor will change their medications.
Oh my God. If there's an alternative to that, like why even
Yeah.
take that medication? Well, Ramon, again, thank you so much for taking this phone call. I know your days off are significant, and I don't take it lightly that you are taking this podcast on a day off. I know how important they are for you to get your rest between shifts. So thank you
Oh,
so much.
thank you. It's my pleasure.
Yeah, man, it was so great to learn about you.
Okay. Well, thank you for having me.
Thanks for listening to the Badass Motherfucker podcast. If you have a coworker who you believe is a badass motherfucker, head over to badassmotherfucker.com to nominate them. My goal is to highlight and share more stories of healthcare workers doing exceptional work in their community who deserve a little bit more recognition. If you enjoyed today's podcast, please give us a like, leave a review, and share it with your friends. Hell, slide into my DMs and tell me yourself. I can't wait to bring more stories your way. But until then, keep being the badass motherfucker that you are.